Well, why don't we go ahead and get started, because we don't have a lot of time for our panel today. So I'm Henry Harbin. I'm going to moderate this. I've worked with the Kennedy Forum for the last couple of years on a number of policy reforms. I actually worked with both Glenda and Ann on some of those. So if you want the full speaker bios, you can go to the Kennedy Forum site. I'm not going to read it out, but it's there if you want them. I'll do a brief introduction, and then they can add to that. So we're going to speak about a number of initiatives that address segregation in the broadest sense, segregation of mental health, that have led to improvements in outcomes for people with these conditions, which is really what it's all about, and from a different perspective. So our first speaker is Larry Morrissey, who is currently Director of Government Relations for Marathon Health. But he's really here because he was the mayor of Rockford, Illinois for 13 years. And in that role, did what is an important job, is trying to link both mental health and health, which is a hard enough task, which we'll talk a lot about from some of our panelists, but also hooking it up with criminal justice and education and housing to try to look at all of the social determinants that have such influence on all health outcomes, but particularly for behavioral health outcomes. So, Larry, will you want to start off, and then we're going to go to Mark after that.
Thank you very much. It's a pleasure to be here, and I think there's great news to be celebrated for the simple fact that we're all together having this conversation, and there's this powerful movement, I think, happening across the country, recognizing that behavioral health, mental health is a critical element of all aspects of health. That being said, I would tell you, part of my job in retirement, post my life as mayor, spent 12 years as mayor of the city of Rockford, Illinois, just about 80 miles northwest of here. Part of my penance, I would guess, and I'd say in retirement, is making up for all the mistakes that I made while I was mayor. One of the, if I had to say the most profound thing we can do if we want to end the segregation that occurs in the world of mental health is to end the segregation that occurs currently, still too often, that separates the fiscal, the financial, the operational, and the cultural work of what happens inside a hospital or a medical clinic with the community health work that's happening each and every day in our communities. And what I realized during my time as mayor, not in a figurative sense, but in a literal sense, I was in the healthcare business. Part of my evangelization, now that I'm no longer mayor, is going around talking to other mayors and telling them, you are in the healthcare business. If you have a fire department, what are most of your calls? Any fire department in this country today, over 80% of your typical fire department calls for service are what? Putting out fires? No, they're health calls. Your police department, if you've got a city like Rockford with a high degree of violent crime, Rockford, unfortunately, had the unenviable position of being one of the most violent communities in the country, under 200,000 people. You're responding to calls for domestic violence, child abuse and neglect, gang violence, juvenile violence. At the very heart, both victim and suspect are typically suffering from behavioral health and mental health challenges. If you're in the human services world, social services world, if you're in a Head Start program, like we operated at the city of Rockford, and you're dealing with children who have been traumatized, if you don't understand that trauma is as much of a factor in one's success or failure in education as any other element, then we are leaving our children behind. The good news is this: there's growing awareness throughout the country that these operations need to be integrated. We see discussions and pilot efforts across the country, not just accountable care organizations, but accountable community organizations. In my last 2 years in office, the work that we were doing has given me hope. December 2015, two important things happened. Our fire department became the first in the state of Illinois licensed to do mobile integrated healthcare. For the first time, we can actually get paid by an insurance company to do a house call instead of just transporting someone to an ER. Groundbreaking, important thing. The second thing that happened is that we became the first city in the nation to reach the functional zero definition for ending veterans homelessness. That happened for one reason, two reasons. Number one, I took the challenge. I thought I was crazy to do so in December of 2014 that I would work to end veterans homelessness. Michelle Obama and the Obama White House made that challenge. But number two, we had a continuum of care that already was in existence. And if you remember that continuum and you wanted to get paid, you had to be a partner in our work to end veterans homelessness. And then the thing that we did there, and I'll tell you, that's ultimately how I got my current job today. When you're in the population health business, the most important thing that I found that you need to do is make a list. Who's in your population? And then you break that list down into the highest risk, medium risk, then the low risk, right? That's what we did to end veterans homelessness. We had to make a list. I was astounded when we found out our challenge to end veterans homelessness wasn't impossible. It was about 130 people. We didn't know that at the start. We didn't know how many names there were, but we built a list, and over the course of the year, we housed about 130 people, and then we demonstrated our ability to rehouse newly homeless folks within a 30-day period. That's how we got our definition. We continue to work that process, and guess what? In my work at Marathon Health today, where we operate worksite health centers for private employers as well as cities, counties, and school districts, the first and most important thing we do with any employer we work with is we make a list. So whether it's Medicaid, Medicare, the federal government, or it's funding coming from a homelessness grant, that payer matters. You've got to make the list, then you got to work the list. So my final thing, I guess, let me say this. If we truly want to have equity in treating mental health, behavioral health challenges, and supporting community organizations that are critical to actually solve the problems, then we have to pay community organizations not out of our grant dollars, but out of our healthcare dollars. And I would have meetings with big players in the insurance world. By the way, they wondered, why is this mayor trying to meet with me? Literally, the Blue Crosses of the world, the Aetnas of the world, the United Healthcares of the world, mayors don't normally set up meetings to want to get paid by them to reduce violence. But I would ask them, if they're a managed care organization in the state of Illinois, we had about 5 of them operating in Rockford, what's the violence rate for those enrollees in your program? And if they can't answer that question, then we have more work to do. We have the opportunity to build community organizations as part of a pay-performance model, but we can't do it unless we evangelize and we realize that those doing community work are just as important as anybody in the hospital or in a clinic.
Thank you, Larry. So our next panelist is Mark Harrison, who's a pediatrician and president of Intermountain, CEO of Intermountain Healthcare. Intermountain is a large medical system, and they've been a leader in recognizing the importance of behavioral health problems on healthcare for a long time, and have done a lot of innovative clinical programs to try to blend the clinical level of intervention for mental health problems with the medical side. So, Mark?
Thank you very much. I'm really glad to be here, and it's always hard to follow a skillful speaker who's a professional speaker in his past life. I'll try and do an okay job here. So I'm actually a pediatric ICU doc, and the reason I'm in the job I'm in right now is the reason I went into pediatrics originally. So I thought I wanted to peds because I wanted to advocate for people who couldn't advocate for themselves. The only problem was I actually hated general pediatrics, so I married a general pediatrician who's really, really good at it, and she's always been the good person in our family. And I went into, so I did pediatric critical care, and my sort of journey's taken me into these leadership jobs. I spent about 20 years with the Cleveland Clinic, doing all kinds of things from clinical jobs to teaching. And then the last 5 years with the clinic, I was in Abu Dhabi, where I, with a team, built our 3 million square foot Cleveland Clinic Abu Dhabi, and got it up and running with people from 70 different countries around the world. And the lesson I took from that experience, in addition to teamwork trumps everything, is that people, no matter where they come from, all have the same strengths and weaknesses. Just everyone's, if you look under the covers, it's all the same. So it doesn't matter what your country you're from, your religion, what your national dress or language is, everyone has the same issues. And I think from a behavioral health standpoint, that's really incredibly valid. Now, how you get at it changes dramatically. So I ended up at Intermountain because of I trained at Intermountain a long time ago and came back to it because we've always taken care of people without regard for their ability to pay. So we're a $7 billion system. We've got 23 hospitals, 180 clinics, thousands of employed docs, thousands more of affiliated physicians, an insurance company that has just shy of 900,000 members, and we take risk on about 500,000 people. So we really have to understand this. We have to get it right, including 95,000 people. In addition, another 95,000 people who we do manage Medicaid for the state of Utah. We touch half of Utahns every year and 75% over the course of a lifetime. You may think we're like a totally homogeneous state. I won't go into detail, but we are not. We've got a lot of diversity. And we actually have a lot of poverty as well as a lot of middle-class people. So Intermountain does have this long history of needing to actually get this stuff pretty right. And for more than 20 years, we've been integrating primary care and behavioral health together. And with really pretty astounding both clinical and financial results. So we find that by doing that, we're able to shorten the time to treatment. We're able to keep people out of hospitals, out of emergency departments, at work. They stay sober better, et cetera, et cetera. And we're able to demonstrate that for relatively modest investments, we're able to make very substantial savings. Now, this only makes sense in the context of payer-provider models, which is one of the things that worries me so tremendously. Unless you have alignment, it's really, really hard to get providers to be interested in doing this kind of work. Now, what's the next gen of this kind of work look like? Because even as good as we are, there's still a lot of gaps. The first gap is we just can't hire enough mental health, behavioral health professionals. Just can't do it. The old models are necessary, but not sufficient. And so we're actually looking very hard at identifying technical solutions to be able to identify the people who really need to see another person versus a person who can actually be screened using technology and determine what level of risk they're at. And we're also using lots of lay people now to try and begin to understand how using lay navigators can actually take care of people's social determinant of health problems. I'll make one final comment. I don't want to go on too long. In order to further understand this, and please watch the news, I can't go into a lot of specificity, we're going to identify, and we have identified 2 areas in the state that are greatly distressed. And we, in concert with community organizations and the government, are going to take on responsibility for all of the social needs for the people in those areas. And we're going to try and see whether we can really move the needle, both financially, but more importantly from a human standpoint, by really addressing the social determinants of health in a very, very thorough and bold way.
That's great, Mark. Thank you.
Thank you.
You know, one thing I'll add to that, I think that there's a lot of times there's not been a lot of recognition by the specialty behavioral system that how much care goes on in the general medical system, whether you have a shortage or a surplus of mental health professionals, and that's not ever going to change. And I'm a firm believer that we are not going to, quote, bend the curve on suicide rates or opiate death rates unless we do a better job within the general medical system of screening, tracking outcomes, and delivering behavioral health better. Not necessarily through a specialist, but in all the things that you're talking about doing. And that's where the collaborative care model comes in and other integrative, effective models. It's really, if you've got half the people who get treated with these illnesses never see a specialist, okay, that's been the case for hundreds of years, how are you ever going to impact the ultimate outcomes here, which are suicide death rates and opiate death rates, which we are in the epidemic, as Patrick Kennedy said earlier. It's the worst in the history of the country, and it's not going to happen unless something happens different within the general medical system. So our next speaker, who's an expert on this, Ann Shields, she's the Associate Director of the AIMS Center at the University of Washington, which stands for Advancing Integrated Mental Health Solutions. I ought to know that. I'm on their advisory board. But the AIMS Center really has been a leader for a couple of decades on a multitude of effective clinical interventions in primary care in the medical system, and it's done a lot of research, but probably more importantly, they've done a lot of technical assistance for major implementations all around the country. So they're not like a typical academic center where all they do is research. They do, in fact, reach out and try to make this happen in a clinical, real-world setting. So, Ann?
Thank you, Henry. I'm a registered nurse by training, and the AIMS Center, we've been training federally qualified health centers, homeless programs, rural health centers, critical access hospitals around the country for about a decade now. And that really is our mission as a subset of that academic health center. So I wanted to talk today about the psychiatric collaborative care model for two reasons. One, it's getting paid for now. That's the big news. So for safety net settings that formerly really had to start up, and in many states still start up on grants, the kindness of foundations, et cetera, there are some opportunities to look at. And more importantly, and just to speak to the gentleman to my left and right who've both mentioned the population health strategy, let's talk a little bit about how that model works. Because the psychiatric collaborative care model takes the psychiatry resource, whether that's a psychiatrist or a nurse practitioner or another identified mid-level profession that's qualified in your state to advise and support behavioral primary care team, and spreads that resource over a caseload or a population of patients. It's a very, very different model. That psychiatrist or other licensure is not seeing the patient directly. They might see 5% of those patients who are very complex, difficult to diagnose. But in general, it's spreading a psychiatrist over anywhere from 50 to 100 patients. In my home state, Washington State, we use about 3 hours a week of a psychiatrist's time at our academic center to cover a caseload of around 75 patients at each of our community health center clinics, 110 clinics in our state. We've been doing that since 2006. So in terms of a proven delivery model with over 90 evidence-based trials supporting it, this is one way to spread psychiatry resources much more thinly but effectively and at much less cost. The collaborative care model also adds another member of the team, two new members of the team, both the psychiatry resource as well as a behavioral health provider. And I say provider rather than professional because, again, the experiments with using peer support and other kinds of licensures or unlicensed staff, those are so important. We're going to need all of those people. This is all hands on deck to make any headway in behavioral health conditions, including the opioid treatment use issues that we're all seeing in our communities now. CMS just established G codes for community health centers and rural health centers this fall. They went into place a couple weeks ago, January 1st. G512 allows those safety nets to bill on a collaborative care model and use and train nurses, bachelor's prepared folks who might have psychology or social work degrees, not master's, but bachelor's level, as well as licensed social workers, psychologists, and others in that team role, working with both the psychiatrist and the rest of the primary care team. So this is a huge step forward. We have, I think, about 7 states now dabbling in that code. I'm happy to talk to anyone here today about how their state might look at this if you're interested in working with your Medicaid administration on that front. Washington State just became the first state in the country to fully adopt collaborative care and pay for it. So our Medicaid, as well as our Medicare beneficiaries in our state, can be served through a psychiatric collaborative care model. Great step forward for us. In our state, we allow those collaborative care codes for Medicaid beneficiaries or those who are dually eligible to cover opioid use treatment, medication-assisted treatment, all manner of diagnoses. I think we're the first state in the country to do that. New York covers depression only. They're thinking about stretching their wings a little as well because obviously the populations we all serve need far more than depression care in these days. So thank you.
Thank you, Ann. Can we hold the questions and one more speaker, and then we've got time for questions. So I did want to add that, Ann, that there are a number of commercial, while Medicare is now paying for this for everybody, including now federally qualified health centers, there are a number of commercial insurers that are beginning to pay. Aetna has turned on these codes now nationally, Cigna for a few ACOs, and some other health plans are beginning to pay. And that is from an advocacy point of view, from the Kennedy Forum and others, that's our next push, is to get Medicaid and commercial carriers both to turn these codes on. And so that when you've got a medical system, it pays, then you're not just having to bill one insurer, which blocks the dissemination of this significantly.
And I would just add, even though these are fee-for-service, it's a bundled payment that comes to the team site, the primary care site, or the behavioral health agency. It's a great stepping stone to value-based purchasing.
Right.
It's giving your providers some experience and covering their costs of learning to deliver better outcomes in a much more efficient way. So even if that's where your state's headed, eventually, it's still, you still got to give folks training wheels.
Our next speaker is Glenda Wren, who's a psychiatrist. She is the director of the Kennedy Satcher Center for Mental Health Equity. I've worked with Glenda a lot, as well as Ann with the Kennedy Forum on a number of these reforms. She's going to talk a little bit about how to increase transparency and accountability by the provider side on delivering these services, where it's done by a primary care doc or by a psychiatrist or psychologist. So,
yeah, thanks, Henry. Thanks for having me here. I think the training wheels is a nice segue to the work that we do at our center. So in the Satcher Health Leadership Institute, we're kind of guided by the principles that you can't leave leadership to chance, that everyone has leadership potential in them, and that they just need the tools. And I think in this overall theme about ending segregation and advancing health equity, I mean, you have done amazing work in the Ames Center, Intermountain. These are all things that if you follow the literature, these are the names you see. And there's a lot of kind of resources that make that possible for the state of Washington to advance it. They are incentivized, but they have, the power behind them versus probably where 75% of people here in the audience work. You're like so far off of that environment, maybe even hearing about some of these things for the first time. And from a health equity perspective, often those providers, they're not even FQHC safety net. They may just be even solo practitioners or smaller health systems that are caring for a large proportion of the population. And so our integrated care leadership program, which was funded by Kaiser Permanente, was really developed to try to help with implementation. And that's where all good ideas go to die, is in implementation phase. Because someone gets a great idea and they're like, hey, we want to do this, read this article, and then they hand it to somebody else that is like, what? And then it's just, people start sabotaging implementation. So we really kind of learned from a 3-year demonstration project at a large public health system in Grady, like what not to do, and then we informed ourselves about what were the common themes. And I know those of you that have done implementation, we could all tell the same stories about the predictable problems that you will face when trying to implement integrated care. And we tried to pull all of those things out and put them into a packaged curriculum that could be taken with like your regular primary care provider. And we have learned from a first round of program sites that participated, and then a most recent graduate that focused on child and adolescent populations, on how do you actually engage primary care providers, how do you distill down all this complicated talk of billing codes to something simple. And what we found really sticks is repetition and redundancy, because there's a learning curve of understanding the language, but also focusing on practical outcomes first, because primary care providers, they're really smart, they know a lot about a lot of things, and if you work closely with them for a short amount of time, they've got it down. And so we talk about measurement-based care. That's really what we push to them as a principle. So similar to doing collaborative care, like the training wheel version of that is like, here's measurement-based care. Here's how you use the PHQ-9 in your work with patients every day. And once you get a group of providers to champion that, they become the health system champions that are kind of saying to their administrative leadership, why don't we have this more often? And you can use a grant to prove like feasibility of implementation and scale from that. So we're really happy with that. And this past round, we were able to get some sponsorship just to speak to the technology piece to work with M3, which is kind of a software service web-based tool to do measurement-based care. And so we're playing around with that. Technology has its own implementation challenges. So all of these learnings we need so that you can take this and bring it to scale nationally. And I kind of think of this as a push-pull. I mean, there's so many ways that we can advance equitable mental health outcomes. We're talking about the healthcare system now, but there's a whole lot to be said for community education and engagement, because if the patient doesn't understand why you're asking me this question about depression when I came for my primary care appointment, you're going to miss that person's depression because they're going to refuse to answer the questions. So I think that's something that, you know, thinking about community engagement is also really important along the way.
Thank you. Well, let me add one thing to what Glenda said, and is that the collaborative care codes that Medicare now pays for and establish, and they've been replaced, the G codes have been replaced by CPT codes, so they're out there now. It requires the use of a standardized outcomes quantifiable tracking tool, which primary care docs do all the time for treating most medical. In fact, they'd probably get sued if they didn't take blood pressure and measure blood glucose when they treat diabetes, whatever. But that's not the norm by the behavioral health specialists, and it's not the norm by primary care doctors when they treat mental health substance abuse. But it is a requirement of the code. You have to use it and do it regularly and drive treatment decisions by it. Glenda and I and others did a paper last year in the Psychiatric Journal called The Tipping Point, which summarized the literature on the research on better outcomes if you use one of these standardized tracking instruments. And sure enough, the outcomes improve from 20 to 60% just using one of these tools. So one of the big advocacy pushes from the Kennedy Forum and others is to have this a requirement, as it is on the medical side, sort of reverse parity, so to speak, that there's more accountability on the medical side. You would use these instruments either required by CMS and insurers or by other quality organizations. We're trying to get this same standard and tracking outcomes on the behavioral side. So we'll open it up now to questions. I understand you can email me a question, but nobody has, so you had a question. Go ahead, but just speak loud so we can hear you.
Yeah, my name is Carlos Navarro. I'm a community leader in Uptown. Also, I'm in a class of 2018 for the 8825 mentorship and a plaintiff in the lawsuit against the city of Chicago with the ACLU on police accountability. So, you alluded to CRSS certified people in your talk, and then you put them in a experimental classification. Can you clarify a little bit?
Sure.
What do you mean by
Yeah.
experimental?
When CMS deliberated and allowed the codes to be used more broadly with the intention of hoping for more uptake in safety net settings, FQs, HCs, rural health, where workforce issues are frankly very, very challenging, often more challenging than urban areas. They intentionally broadened to non-licensed staff. And they spoke very directly about their intent to do that. I have to say, with my academic hat on, we don't have as much experience with that as we do with, say, a licensed social worker or a nurse, a registered nurse. Is it still? It's the right thing to do. It's obviously the right thing to do. Our advice for those who are using less experienced or non-licensed staff is essentially expect to build a stronger mentoring and training program. Don't let anybody fail because they didn't get the support they needed for a role that is new to them. So
Are there other
that was
questions
my intent.
from the audience?
Yeah.
Okay.
Good afternoon, or good morning,
Yeah.
rather. My name is Joyce Ochoa, and I am an attorney and do disability rights. So most of what you're saying does not make sense or apply to me because it's a whole different ballgame. But what I was able to gather from Mayor and Dr. Glenda, you spoke about advancing equity. And I'm so glad you use equity because we know that mental health manifests differently on different people. So we can't say it's equality. It can't be one size fits all. So you're talking about implementing collaborative systems, which I'm so encouraged to hear because it sounds very comprehensive. is there also some sort of social training? You spoke about community work. So we know on the South Side, people suffer PTSD trauma similar to 3rd and 4th tour Afghani veterans. And these are children, and that's traumatizing. And a lot of the time, depression and PTSD in those communities are normalized. So is there training in these healthcare provider facilities or with these PCP caretakers for how to identify how mental health manifests in different communities?
I can just briefly speak to that because we also have an NIH-funded research project looking at culturally centered integrated care models. And what I'll say to that is I'm really a fan of looking at the outcomes because the outcomes are what matter. And for well-crafted studies that are implementing collaborative care, for example, in OBGYN, the health disparity population did better, which makes sense because they're not getting the same quality of care. That is to say that you might see culturally incompetent care or less than adequate care resulting in higher no-show rates, poor engagement. It impacts help seeking. So I think that there's an academic answer to that question, but like the solving the problem answer is yes, you need to engage with the communities in terms of educating them on recognizing hidden trauma narratives, addressing and having community conversations, and recognizing there's all different pathways for healing. And it's not all requiring healthcare systems to have healing in communities. And then having a segue of transition. This is like a public health approach, essentially. So that's a stepped model that starts in the community and ends with specialty behavioral health care. But we need to have the measures. If you look at healthy people right now, the 2020 metrics, there's like maybe 4 for mental health. And one of the targets for depression in adults, the screening target is like 2%. How is that the goal for primary care? There are flaws when we can't measure things properly at a population level. That results in a disparity in attention that mental health suffers from compared to other conditions that we can do a blood test for.
Let me add one point that I'd like Mark to respond, which is this model, if it gets fully disseminated by all payers, which I think is what's going to happen, hopefully, a pediatrician would be screening for mental health and substance abuse problems as a routine part of what they do. And that's what this model is. And they would treat those people who don't need to go to a specialist with the extra help from a behavioral health care manager, licensed or unlicensed, and a consulting psychiatrist. So it extends but this is the model I think that would happen. So you would catch these things, you're talking about prevention earlier and all this. This is what would allow, because it would pay an OBGYN to do this screening and tracking, it would pay for a pediatrician. That's where you need to start identifying these problems. So I don't know if that's what Intermountain's doing, Mark, but
that's essentially exactly what I was going to share. I don't think parsing behavioral health from somatic health is helpful at all. So I think that you integrate that into the whole package, and it actually destigmatizes, I think, to some extent as well. The only other thing I'd say is I do think there's cultural competency training, which is very, very important. I think it's helpful, and we do this as much as we can, to try and have our clinics and neighborhoods staffed by the same people who live in the neighborhoods, right? Of whatever flavor of people they are, right? Because I do think that in addition to actually the cultural competence, there's also something I think particularly for kids to be able to see role models of all different kinds who look like them, talk like them, speak the same language, same religion, et cetera. And I think that's really helpful. I'm not as academic, so I don't know if that's borne out by research, but it kind of makes sense probably.
Having a cultural broker to engage with community and establish trust, institutional trust.
So go ahead, Larry.
So I would just say currently I work for a for-profit only employer-facing healthcare company, Marathon Health. When we go into an employer site, we work on a fixed fee basis. I love it. There's no billing. Actually, you get one bill once a month, which is your total bill for the year divided by 12, right? It's one page. Wouldn't that be nice if all healthcare was one-page billing? So what we do when we go into a site is we do a very robust health history and risk assessment. We try to incentivize the benefits program to require that members, employees, do the health risk assessment, get a biometric screen. And we started adding things like a PHQ-9, I think is that right? Mm-hmm. Yeah. I'm a recovering lawyer, by the way, who didn't study healthcare, so I'm picking up the terms as I go. But But I'm also, I'd say my bona fides for this conversation is I'm the child of an alcoholic who's been sober for over 30 years. And getting the whole health picture, I like what was said about not really distinguishing between behavioral health and physical health. It's all health. Understanding what that is and doing risk stratification is absolutely key, and then you got to work the list and do engagement. I think that model actually can work in a lot of different settings, but employers, I believe, are starting to lead on this nationally. And the employers that we work with pushed us. We now offer behavioral health in addition to integrating EAP programs and the others. And you asked me about going at risk. We're at risk as a private company and all of our contracts. 10% of our fees are at risk for hitting AAA metrics. And by the way, when I was mayor, when I would meet with insurance executives, and they would challenge me, would you be willing to go at risk with your fire department, police department, whomever, delivering services, trying to reduce violence, et cetera? And I said, we're already at risk. We don't get any money generally. Our taxpayers already fund all of our police services, fire services, et cetera. So what I tell mayors now today is, if you're looking for revenue based on performance, we should be talking about healthcare dollars, and these accountable community organizations is a way to do it.
Jay? You speak up.
A quick question about, and I'll try to get rid of the abbreviations, the OPEB, the other post-retirement benefits that you had in your program. I'm concerned about parity for the people that were spoken about this morning that face not only their constituents, fire departments and police departments, but also higher levels of behavioral health problems. With OPEB coverage, which is post-retirement, is paid out of the city, county, and state budgets, which are being attacked now, reduced all across the country. It seems like not the really great time to be reducing the coverage and the exposure to police, fire, and teachers that retire at 50 or 55 in that 10-year period of time when they might not be able to afford it or they don't have coverage just before they go into Medicare for 10 years. Do you have any thoughts about that?
Sure. So this varies across the country in the level of benefits, even by city. In Illinois, if you are a city that historically provided post-retirement health care benefits, you're on the hook to continue to provide them. They're considered part of your pension system, which can't change once it's been offered. Our city didn't offer them. You can come onto the plan as a COBRA member. You can pay the full boat of the full premium, but it's very expensive coverage. What I wish we had done while I was still in office, not because anybody was legally requiring it, just because of my own experience out of what I would say is the moral and ethical thing to do when I see, by the way, the conversation about trauma, cops, firemen, first responders have a huge incident. Phil Eaton, I know his team is here from Rosecrans. They run the Rosecrans Florian program, one of the only first responder facing inpatient behavioral health programs in the country. What we know by experience is that they're at high risk for trauma-related PTSD, and that's why I think it's morally an imperative to keep them covered. Teachers, by the way, a lot of them go through the same experience, vicarious trauma experiences. So what we were looking them to do is, and the current mayor now, and Mayor McNamara in Rockford is looking to bring it on to do is, can we bring retirees onto our program to allow them to have access to our on-site clinic, even though they're not formally given that right as a member of the health plan. So there's a lot of things going on, I think, that really speak to the issues that you're talking about, because ultimately somebody will pay for those failures in our gaps in care.
Well, I want to thank, we're going to have to stop, I'm told, but I want to thank you all for coming to this panel, and also our panelists for doing a great job.
Great job. Thank you very much.